Welcome to the Medical Report. Our guest today is Dr. Robert Huxster. Dr. Huxster is an orthopedic surgeon, a member of the Chester County Orthopaedic Group, and he has a specialty of hand surgery. So welcome, Dr. Huxster, to our TV session on medical affairs. We'd like to know a little bit about your background as a hand surgeon. Tell me what was involved in this training.
Sure. Like other orthopedists, I did a medical school residency and in orthopedics for 5 years, and then a hand surgery fellowship. In my case, I did that in Philadelphia at Jefferson, the Hand Center in Philadelphia. And I've been practicing with a mixed practice, but including a large percentage of hand surgery ever since.
So there's a fellowship in this particular field, which makes the individuals who learn this expertise in what they're doing. So what we'd like to talk about are various issues of hand surgery. There's lots of surgery and problems that are other than traumatic or injuries that people would suffer. So let's start with the topic of a carpal tunnel syndrome. Carpal tunnel syndrome. Could you define that for us and so forth?
Sure. Carpal tunnel syndrome refers to a situation where people begin to experience discomfort in their hand. Typically, it is numbness and tingling. It involves primarily the fingers on the thumb side of your hand, your central fingers, not so much the pinky finger. It usually is sort of an insidious process where you begin to notice it occasionally awakening you at night or occasionally during the day, and often progresses over time so that the episodes become more intense, are associated with pain, sometimes pain running up the arm, and more frequent. And it can progress to the point where you have constant diminished quality of sensation or permanent numbness in your fingertips.
Is there any loss of power in the hand, the ability to grasp things and so forth?
There is, but that's usually subtle. Most of the power comes from muscles farther up in your hand, in your arm, and even the muscles in your hand are primarily provided for by a nerve other than the median nerve that is involved in carpal tunnel. So most people don't notice too much loss of power, but you can. There is some muscle in your thumb that in some people, when it is affected, will notice difficulty with pinch tasks, opening jars. More often people notice that they have trouble with tasks because they're not feeling the object properly. So buttons and items like that, zippers, become difficult.
Mm-hmm. Are there any diagnostic tests that you use to determine that it's actually carpal tunnel?
There's a series of tests, primarily exam. There's also an electrical test. The diagnosis is primarily made by physical exam and history. We confirm this with an electrical test called an EMG nerve conduction study. We also use that test to help differentiate other electrical problems in the arm that can look similar to carpal tunnel. For example, a pinched nerve in your neck can produce a similar pattern of numbness. So we want to differentiate those things so we know which one we're treating.
So the EMG is an electromyogram. It's measuring the nerve potentials, right? By sticking little needles into the hand?
There are two parts to it. There's an electromyogram part, and there's a nerve conduction study.
Okay.
The nerve conduction study involves electrodes placed on the skin that will produce an electric shock, and you can measure how quickly that is propagated down the nerve. So it's not a fun test. You feel that as electric shock. And the second part is the EMG part, or a myelogram part. It involves skinny little needles that are actually electrodes placed into muscles, and usually that's done in a series of muscles all the way down into including the thumb. And again, it's not a lot of fun. It takes to do the study in both hands probably takes close to an hour. And obviously, there's a bit of an art to it.
So, given a high degree of suspicion, you still want some kind of confirmatory test before you do anything. I suspect. Is that correct?
Typically, we'll get the test, and again, we'll often get it primarily to discover if there's a second problem that would look similar and might be confusing.
Okay. Is there any known cause for carpal tunnel syndrome?
We think that it's primarily a predisposition. to develop the syndrome. But once you're prone to it, and many of us are, it's certainly affected by activity. So there's a combination of things that seem to play a role. Some people are just likely to get it, or more likely to get it, and then what you do with your hands, your arms, will certainly contribute. So aging plays a role as well. So it's those three things. Everyone talks about repetitive motion, things like keyboarding, and we certainly do see an association there, but some people can keyboard 8 hours a day all their lives and not have a problem. So it's a combination of predisposition, something that happens as you mature, and then use will play a role as well.
Are there any medical disorders that it's commonly seen with this?
There are certainly several things that can predispose you. The typical one would be hypothyroidism. Diabetes can make you more likely to have it. So there are a variety of medical issues that will make you more likely to experience carpal tunnel syndrome.
Okay. Well, let's talk a little bit about the treatment of this particular disorder. Can you tell us what you do to correct it?
Well, there's medical treatment or non-operative treatment, and that can be as simple as not doing something, avoiding things that irritate it or bother it. Wearing a splint at night can be quite helpful. Many people experience symptoms at night. There's the possibility of medication playing some role. No one's proven it effectively, but any vitamin B deficiency, B6 or B12, certainly can make you more prone to it, so taking those may help. And then finally there's surgical management, and many times that ends up being the right answer. As a matter of fact, there was a study done quite recently that showed that the most cost-effective way of dealing with significant carpal tunnel syndrome was to go ahead and have the surgery, get it done with.
Okay. Could you tell us what's involved in the surgery part of this?
The goal of the surgery, I made a little sketch on my way over here sort of hurriedly. It's not immediately clear what I'm drawing here, but what I've tried to depict is the space we call the carpal tunnel. So this would be as if I was looking at my hand like this, sliced like so, through the carpal tunnel. And what we're seeing here would be the bones. This would be the tunnel, and across the top is a ligament. So it's a passageway made of bones on three sides and a ligament across the top. Inside that passageway are multiple tendons, the ones that bend your fingers, and then the nerve, which is the yellow spot there. As the tendons are enlarging with this process, taking up more space as you age, and then perhaps with swelling with use, there's not enough room for the nerve, and that's what produces these symptoms. So the surgery is aimed at cutting this ligament. That's the important part of the surgery. So we want to cut this ligament, thereby making that passageway bigger, makes more room for the nerve, and the nerve, which is really a kind of a passive victim in all of this, is relieved from the pressure on it and can behave normally again. So the common or the typical way of accomplishing that is to make an incision in this part of your hand, usually about that long. You work your way down through the various layers until you've released the nerve by cutting that ligament. There are variations on the theme that involve shifting the incision or smaller incisions, but that's the essence of it.
Okay. And the recovery period is fairly brief, I understand.
It's really not a bad surgery. For most people, whichever technique is used, for most people the surgery is relatively comfortable. I'd say half the people that have the surgery tell me that I took one of the pain pills because I thought I should. And you can use your fingers right away. Most of us do tie your wrist up with a splint for a few days after the surgery, so there are a few limitations. Stitches are out by 2 weeks, 10 days to 2 weeks. So most people can do things like dress themselves, use the hand to eat immediately, things like driving a car after a day or two, but heavy gripping, grasping, hand tools, gardening, that's going to be more like several weeks.
Very good. Well, I think that's a pretty good evaluation of a disorder that's fairly common. And another one that's very common, if you could discuss a bit what is this Dupage Contracture and tell us what that is.
Dupage Contracture is quite interesting. It's something I've gotten quite interested in myself because I have it. It is the transition of a layer in your palm called the palmar fascia into a tissue that's more like scar tissue. The palmar fascia is important because it keeps your skin from staying put, or keeps your skin from sliding around. It keeps your skin staying put in your palm, unlike, say, the skin in your forearm, which slides all over. This skin here is anchored by that fascia. With Dupuytren's disease or Dupuytren's contracture, the fascia changes and it becomes more like scar tissue, and you will develop bands or pits or nodules. If the bands cross a joint, superficial or closer to the skin than the tendon or the joint, but if they cross that joint, they'll begin to inhibit your motion. So the band will restrict your ability to straighten your fingers out. The disease, which is a hereditary trait or tendency for the most part, will tend to progress. So over time, you start off with a band that you may notice, and you may live with that for 10 years, and then you'll realize it's starting to inhibit motion. It's a gradual process. At that stage, when it starts to inhibit motion, we start thinking about doing something about it to restore motion.
So what is the technique that is used to correct that?
Well, the traditional approach has been to make skin flaps, large flaps of skin, and elevate them up so you can get to those bands and remove the bands, and that's still an effective technique, and many times is the only practical technique, particularly when the process has evolved to the point where the finger is markedly impaired or markedly crooked. But at a less severe stage, there are less invasive techniques, one of which I went to Paris to learn 2 years ago. This technique is called needle aponeurotomy, and it involves using, under local anesthesia, just the needle itself that you would administer the local anesthetic with to break these bands up. And it's done as a series of steps. Once you've succeeded in breaking the band, you can restore the ability to extend the finger back out again. And it's sort of a different way of thinking about the disease process. With the surgery, it was almost like you were trying to cure it, which you really can't do because it's a trait and a tendency, and it forms again and recurs. So it's more of a maintenance approach where you use the simple technique like needle aponeurotomy, or you've seen advertised these injection of collagenase. I've seen that advertised in the papers a lot recently. Is another technique of trying to do the same thing. Break the band up and restore the ability to extend, but do it with something that's simple and doesn't set you back, doesn't impair your function significantly. And if you need to repeat that again after 2 or 3 years, you can. It's easy.
Well, it sounds very similar to minimally invasive surgery of other parts, in a sense.
It's really not. It's not surgery in the traditional sense because we're really not making incisions, but it accomplishes the same end, and you're really using the tip of that fine needle as your scalpel.
Mm-hmm. How many, I guess, little injections do you have to do to?
It'll depend. It'll depend.
Yeah.
It is usually multiple. If you're doing a single finger, it may be that there'll be 6 or 8 little spots that you work. What we do first is use a tiny little needle to numb up the spot where we're going to do the work at each site. We mark them out or map out a plan for the procedure. Inject each of these spots with a little tiny needle. Once that spot's numb, you can use the larger needle. Most of the sensory fibers, the nerve fibers, are on the deep side of the skin. So these bands, which are below that, don't have much sensation. So once you've numbed the skin, you can actually work on the band without really causing much discomfort. And usually right then and there, as you're working, you're gradually popping the band in several places and end up with the finger back out straight. And the patient can walk away saying, "That's nice."
Well, that sounds like an innovation. I haven't seen that done personally to anyone, but that certainly sounds excellent. So we really appreciate this discussion about carpal tunnel and Dupuytren's contracture, 2 of the more common things that people will get as they get older. Please stay with us because we're going to have another session with some more problems that people can develop in their hands. So we'll be right back in a few minutes.
You don't have to go